We're going to talk a little bit. We have two speakers who both have practices that are primarily that are all thyroid, and sort of the idea of setting up a private practice that's all related to thyroid, and they're going to discuss the ins and outs of what's involved in that. So our two speakers are Woody Sistrunk, who's sitting right next to me, and Bob Levine over here, and we're really excited for them, and hopefully they're going to have a presentation and there'll be plenty of time for you guys to ask questions as well.
Thank you. Bob, why don't you come over here if we're going to be doing counterpoint, because I'm afraid that we would be slugging back and forth across the room. Okay. And so Bob and I are going to kind of present this talk together, and so I have slides together. We're going to go ahead and get started with that. And so one of the things is that we are both thyroidologists out in practice, but we both have different styles. And I want you all to appreciate how some styles are really different, and how although we do roughly the same thing, there are very different styles. And so let's talk a little bit about running a successful thyroid practice. I know we both, your syllabus said ultrasound, and I see you have your slides with you. I was to talk about nuclear medicine in the outpatient practice of endocrinology as well, and I'm happy to do that if we have time, if there's interest. But let's talk a little bit about having a practice. Now, should you get a microphone? You have a microphone.
I might.
Good
yes,
golly.
Yes,
he has a microphone. So we talk about what is success, where to even start, why a thyroidology practice, and we talk about some of the optimum parts of having a thyroid practice. Now, let's talk a little bit about success. So success can be measured a lot of different ways. You think about professional satisfaction, personal satisfaction, but you also want to consider time with family, making a living. You got to make a living. You got to pay the bills at the end of the month, plus adding a sense of accomplishment. And so all of those things are important. Would you agree?
I would agree, and recognize that how you're going to measure success is going to change throughout your career and throughout your life.
Very much so.
And if I look at, I've been in practice now for 25 years, if I look at what measured my success 25 years ago, it was much more weighted to the economic and professional success in the practice. 25 years later, I measure it much more in whether I get enough time off to spend time with my family and to come to meetings like this. So it has changed.
Very much so. Well, we talk about where to even start, and I talk about where did I start. I'm 42 years old, and I have not been in practice for 25 years, but I've just about pulled all of my hair out. But I had an unsuccessful basic laboratory year that, I had mice that just attacked each other and attacked me and scared me to death. And so mainly that's what made me pursue thyroid ultrasound and nuclear medicine certification. I joined a group of endocrinologists, went into practice about 2001, and I owe a lot of what I started with to them because, really got established. Although it was my hometown, it got me established in the community. And you?
I was in a fellowship and actually never finished my fellowship because I took a temporary position in general medicine at the university, ended up attending on a general medicine section and attending on the endocrine section without having finished my fellowship, and then spent many years there still attending and ultimately took my endocrine boards. When I left, I originally went into general internal medicine with a side of endocrinology. That lasted 6 months. I then joined a general endocrine practice and was with them for 3 years, and then set up my own practice 20 years ago. When I did that, it was a general endocrine practice, including diabetes. The diabetes lasted about 5 years, and we eliminated that. But I still did general endocrinology till about 8 or 10 years ago when, after taking the ACE ultrasound course, I decided I would do nothing but thyroid at that point. So you can remodel yourself throughout your career. You don't have to be stuck to one thing. And that's one of the beauties of private practice, is that it lets you redefine yourself at any moment. And
but you got to work it.
Yeah,
you got to work it.
At one point, I was seeing general endo, and I made a decision, I'm just going to do thyroid.
How do you do it? Do you release patients, or you continue to
No,
Right.
well,
We'll get into that. We're going to talk about that.
Yeah,
because the thing
yeah.
is that, you got to review yourself as a subspecialist, And so the thing is that you got to say, when you're on the front end, whenever I see anybody, I say, who's your primary physician? Oh, you don't have one? And you have good insurance? Well, let me refer you to internist X.
But in terms of that transition from general to subspecialty endocrinology, what I did is I brought in a partner who then took all of the non-thyroid as well as some thyroid, and I just said, all right, the patients aren't going to leave the practice. And I brought in a nurse practitioner, and she took over all the diabetes, and we never did say to the patients, you have to leave, but I just started doing nothing but, and the practice itself took over the other things.
But I told my patients that I had diabetes. I said, this is my career choice, and this is what I really have always wanted to do, and I'm going to do it. I'm going to make sure your transition is good to an endocrinologist that will take care of your diabetes. But I had a chance to do that face-to-face, not in a letter. Over about a year's time I did that. And that's critical, That's really critical. Some of them have even come back to see me about thyroid issues from there. As you get started, one of the things you have to be willing to do, and I know you all probably, like me, had student loans and had other things going on, and you will owe money to people, but you get out of practice and you've been driving the same old car forever. And so I'm still driving that car, and I have the antique car tag on it now. But one of the things when I came out of fellowship was I wanted to do nuclear medicine in the office. I wanted to do ultrasound. And I knew that that was going to be an expenditure of about $45,000 for those two things. And so I just said, this is what I want to do. This is what I need to do. I will not get a new car. I will drive same old car. And I know Steve Jobs sold the VW bus. I didn't have to sell a VW bus. I just didn't buy a new car. And sure enough, that's what it took to get me going. And it worked from there. But, in a group practice, I really wanted to just do thyroid. And, sometimes you'll come up against some resistance if you're in a practice because everybody says, oh, thyroid is easy. Well, gosh, after 2 hours of molecular markers this morning, thyroid is not easy. And so, but if you really want to do this, it can certainly happen. Now,
just to go back to that economics for a second, when I had left a 3-person or 4-person group that I was with down south, and I moved up to the Northeast to do it, and I took 2 approaches. One was, as Woody said, you need to come up with some cash to do this because you're not going to see revenue for the first 3 months or so. You're going to be billing. The patients are not going to be banging down the door. They're going to be trickling in. So you have to calculate what you're going to need for staff salary, what you're going to need for equipment, what you're going to need
to keep the lights on.
Yeah, for all those expenses. And I calculated that I was going to need potentially, you said 45, I calculated as much as 90. It really only worked out to about 50.
Right.
But I took out a line of credit and actually used it as a second mortgage on my house at that point. But I took a bank loan that was a line of credit, so I didn't have to pay on the whole lump, but I was able to draw on it, and it was paid off by the end of a year and a half.
Right.
But that was the way to get started with it.
So a lot of places in the country, endocrinology equals diabetes doctor, and endocrinology equals diabetes internist. And, gosh, some of you all may be keen to join a practice and be a diabetes internist, but I really wasn't. And so the thing is that by all means remember that you may become a diabetes doctor by association. So how do you differentiate yourself? Well, for me, gosh, I started writing letters. Everybody who came and saw me in the first year in practice, and I said, by the way, I wanted to let you know that we have on-site nuclear medicine and thyroid ultrasound. If you have a patient that needs prompt referral, such as with a thyroid nodule or with hyperthyroidism, please call me at this number, and I will make every effort to get them in a timely fashion. And so that's just simple things. That's just gratis things that you can do for free advertising there.
And if you're going to do the diabetes on the side as well, if you're going to do a general endocrine practice, it's very important that you only take patients by referral.
Right.
They have to have a primary care doctor to get in, because 2 things will happen. One is if you take them just because they call and say, I have diabetes and I don't have a doctor, you're going to do nothing but diabetes. That will occur. The second is that the internists in the community will be very loath to refer a patient to you
For fear of stealing them.
If they think that you're going to also be doing general medicine. So you have to make it perfectly clear it's referral only. When I started 20 years ago, people said to me, it will never work. You won't be able to do endocrinology only. You have to do general med. And that, in the community that I went into 20 years ago, the pattern was cardiologist did general med, pulmonologist did general med. That has completely changed now. But I kind of broke the ice by saying, I am not going to ever see a patient for general med. And the diabetics would say, can't you be my primary care doctor? This is the only problem I have. But they will come into the office, and you'll want to say to them, why is your blood sugar 475? And they realize a good way to get around it is to say, I have belly pain.
Yeah, yeah. You know, for both of us, one of our, a mentor that you will probably hear mentioned is a guy named Jack Baskin. You know, I was in my fellowship at Mayo. Do we have any Mayo trainees here? We have any Mayo trainees? Boy, this is sad. I was in a fellowship at Mayo, and, you know, I was doing all of this thyroid stuff, and I met Jack Baskin, who's in private practice down in Orlando, Florida. And I said, you mean you really just do thyroid stuff? This is about 10 or 11, probably about 11 years ago. And he says, yeah, that's all I do. I said, just thyroid stuff? And so he was a real mentor to me. And again, this is really becoming a reality if you're interested in it, because it's doable. But you got to work it some. So, you know, I eventually left a group of endocrinologists and started my own thyroid practice. And gosh, I never looked back. And it's been great. I guess by 1 year in practice, I got $80,000 loan when I moved from one practice to the next, to build out a space, to do everything else. And it took me about a year, but I was out of debt inside of 1 year's time. And so, but there are a lot of benefits of being on your own or just being in solo practice. Let's go through some of these. You want to talk about some of these?
Oh, why don't you start?
Yeah. Okay, so what are the risks? I mean, one of the main risks is that you're the one responsible for all the, you're in charge of paying for it. You got to take care of the business. You could make the wrong decision. You could have a big loss, and the office protocol is your responsibility. But you look at the flip side of that, is that, you know, you're only paying for you. You have the option to hire good employees. You know, do you want fries with that? You know, unfortunately, a lot of medical professionals are so cheap that they just hire whoever will come in off the street. Oh, you can take over my billing? You worked in a gas station before? Literally, you know, I've been in offices like that. And so the thing is that office protocol and quality control becomes your responsibility. But then again, you're not having to convince 5 other partners that things are important and they should be better than that.
And to expand on that for a second, if I compare the personnel that I have in my office, some of which have been with me for as long as 12 out of the 20 years I've been in this practice, I have a magnificent staff, and when I need someone, I can interview 8, 10 people and decide between 8 or 10 nurses or medical assistants or front desk people. If you're working at a group practice or in a university, you are assigned someone, and if that person is not doing well in the cardiology section and antagonizing everyone around them, they'll be transferred over to the endocrine section, and then that will be your secretary. Yeah. So I've managed to hand select and pretty much pilfer the best personnel from all the other practices in the area. So if my current office manager was an office manager for another practice, and he happened to be a friend of mine, so he didn't hate me when I stole her away. But that's where I came up with most of my personnel, is by looking around and saying, who's really good, and then giving them a little better offer than they had. And when we start talking about billing, I'm going to tell you an interesting story of how I got a billing person.
So back to this is what we mentioned before, a thyroid practice. You know, one of the things is that when I went from being a general endocrinologist to just thyroid only, I started getting a lot of referrals from people who had never referred to me before, and I couldn't quite figure out why. So I talked to one of them, and he said, well, you know what? He says, anytime I would send a patient to the old practice, they would get sucked up into that spider web of diabetes care, and they would take over the cholesterol and take over the lipids and take over the diabetes, and I'd never see them again. And so one of the things that all the doctors know now is that, gosh, I will get you on the right track with your thyroid, and nodules and things, like Bob is going to say, will follow forever, some of them. But I would say, making sure that you do get a nice letter back to the referring physician and you get them stable. And once they're stable, you go from there.
Yeah, and I think you mentioned this later on, but that letter back is your best advertising.
I've got a bad letter in here too. So I'll show you a bad letter and we'll go over a good letter.
I did very, very little advertising when I set up to begin with because I had decided I was going to take patients only by referral, and so I did not need to direct advertise to patients. Where that works is word of mouth.
Right.
Having been there for the length of time I've been there, most of the patients who come in, when I say, how did you hear of us or how did you end up with us, half say it was my primary care doctor who just referred me over, but the other half say, my primary suggested I go to Dr. X, but all my friends who all seem to have thyroid problems all go to you. And they said this is the place to go. But that letter back to the primary, and Woody already mentioned this, that in that letter, it wasn't just, thank you for referring Mrs. Jones, but in that letter there was a paragraph that said, I do full service thyroidology, and we do have these services on board. So the doctor gets a very comprehensive but short and readable letter, and they look at it and say, this is where I want to send the next patient. They get another, same thing for thyroid ultrasound.
Pay $500 and get a logo too.
Yes, logos.
Literally. I mean, you have people that will.
But if they get an ultrasound report back from you that is understandable and has a wonderful conclusion, and the report they got back from the hospital 2 months earlier when they sent the patient over for the same issue,
missed the nodule completely,
or gave them 2 lines and no conclusion recommendation, but just said there is a 1.7 centimeter nodule, end of report, whereas ours say there's a 1.7 centimeter nodule, it has these as suspicious features. A biopsy was done and the biopsy came back indicating X. Now they've looked at it and said, gee, where am I going to send my next patient?
So we talk about what is a state-of-the-art practice, and this is something that is ever evolving, but I would say, number one, the ability to get new patients in. And so, we're not primary providers. The ability to remain consultative, the ability to return patients to their primary provider, and also the other practice enhancements, which you don't have to start with all of these, but I would recommend it, is a point-of-care, CLIA certified lab, thyroid ultrasound and biopsy with the ECNU certification and the AIUM accreditation. Thyroid nuclear medicine is something that you all may want to add, and thyroid cytology, for own-site adequacy, is one of the greatest things I've ever seen. But you got to make yourself available. It's what we do is very complicated to the outside world. The thing is that no one refers to an endocrinologist until they've lost their kidney, their eyes, their foot, or their leg. But you get a TSH with the star bite, and gosh, they want your help all of a sudden there. Make sure the physicians can get back through to you. And, some of you all will get busy really quick. And, so how do I handle that? My nurse will come knock on the door, and she says, Dr. Jones is on the phone. He's got a lady who weighs 105 kilos and has a TSH of 50. Tell him what to do, and we'll see her in a month. So I pick up the phone and said, hey, I'm planning to see your patient. Thank you so much for sending. Let's get her feeling better before I see her. Go ahead and get her started on Synthroid 100, and I'm seeing her inside of a month. And so by doing that, they have established that, hey, you're worried about their patient. And number two, the patient is feeling better by the time you see them. And number three, that, you get them on the right track, you get them back to the primary provider. Because that's one thing, is the availability of appointments gets difficult. And so if you can get ahead by getting them started on the medicine and get them feeling better, that's a great boon.
As you are,
right.
Give your voice.
And I have a lot of doctors that'll just send me labs or advice and say, what should I do now? I don't mind that a bit. That's great fun, One of the things you got to remember is we may all very well be thyroid oncologists soon. One of the things there is a surgeon from MD Anderson who grew up with me, used to beat up on me, named Eric Sturgis. Anyone know Dr. Sturgis? I saw him at a meeting once, and he says, what are you doing here? I said, this is what I do. What are you doing here? And I said, can you believe I'm in Jackson, Mississippi with a thyroid practice? And he is an Masters of Public Health. He says, give it 5 years. You're going to have a thyroid cancer practice. And certainly, this becomes the people who we follow long term in our practice. And so certainly, there's a huge need for that as that continues to grow.
hypothyroidism.
And you have the Wilson syndrome center of the world, don't you? But remember, Dr. Oz, every time he mentions the thyroid, somebody's going to want to get seen by a specialist, you know. So I would always say this, is that to be a help, but don't be a guru, you know. I mean, you know, gosh, if you have a cash pay practice, and, you know, but which I do not, but I would always say this, always be complimentary to the primary provider. Gosh, the nurse practitioner did an excellent job of starting you on that 25 micrograms a day for the TSH of 200, and she was on the right track, but let's get it moved up a bit, then we'll get you back to her care in good shape, you know? And always be complimentary of what was going on. Don't be a TSH clinic, meaning that, you know, gosh, there comes a time where, you know, for me, I don't have a nurse practitioner yet, because once people get stable, I say back to primary care physician and their nurse practitioner. But I would say, there may be a need for this, and Bob has a nurse practitioner, and for me it's probably space more than anything.
Yeah, and we once a year.
So in the way of hospital consults, I've gotten to where now I'll go see hyperthyroidism in the hospital, but you know, when you get called with an 85-year-old person on tube feeds that the TSH is 10, I usually pick up the phone and say, hey, they need to be on thyroid replacement or not. And, you know, this is, you know, but I think that this is where you need to do more phone calling. Unless you're into a hospital contract that they're forcing you to go and do general endocrine things. But I would be quick to say that I don't desire to do hyponatremia at 3 o'clock in the morning ever again in my career if I can help it. You might be the same, you know.
And that is
right. So we talk a little bit about the weekly calendar, and we've already kind of beat the dead horse here about seeing new patients and the availability to see new patients. But I was going to kind of show a little bit about what my calendar is. Now, so on Monday, I usually see up to about 25, usually no more than that, usually 23, around in there. I see about 12 to 15 at times new patients on Tuesdays. And we do a few FNAs along the way. I'm dropping this number down so I can get FNAs in as I see the new patients. I do my thyroid uptakes early in the morning. I do ultrasounds all Wednesday morning, and ultrasounds and biopsies. I see a few new patients or follow-ups on Wednesday afternoon. I do follow-up ultrasounds Thursday morning. Thursday afternoon, I see about 8 to 10 follow-ups. And I usually do on Friday up to about 20 patients in follow-up. You know, this is the ones that I see back in follow-up of the TSH, and just quick follow-ups there.
Wow.
It's a busy week at times.
Wow, it is.
Yeah.
All right, let me start with mine. I'll start with Wednesday. Either go skiing or kayaking.
Good.
And the other 4 days are identical to each other. There's no separation. I don't have a new patient day and biopsy day and a time to do procedure. Every day is the same. And basically, I see 2 or 3 new patients a day. I give them an hour. I see usually a total of somewhere around 16 patients a day total. If it's a follow-up that I know will require an ultrasound, I give them 30 minutes of time. If it's a follow-up that is not going to need an ultrasound, that is a thyroid cancer patient who's on an alternate year schedule for ultrasound, someone with hyper or hypo that I'm still following because I like, they get 15-minute blocks. And I block off an hour for lunch, but I typically only get 30 minutes because I'm about 30 minutes behind by the end of the morning. I'm about 30 minutes behind by the end of the afternoon. I try never to be more than 30 minutes behind. I'm usually pretty good at that. But I'm seeing about 16 per day, 4 days a week. The only downside is at the end of my work day, I've done typically 10 or 12 ultrasounds. And I have to go home and sit down for about an hour and a quarter.
My family is just used to this. This is what Dad does at night. Look at pictures.
Dictate those ultrasound reports. But by taking Wednesday off, it means Monday night is an absolute. I can't plan on doing anything Monday night because I got to get my dictations done. Tuesday night's a little flexible because I can always do those dictations on Wednesday if I need to. Thursday is an absolute, and then Friday is flexible because I can carry them over onto the weekend. So I have 2 nights out of the week that I have to do homework. And my kids recognize that homework is not just something you do in school for a lifetime.
So how many employees does it take? This is something that I look at, and my brother, who is in a big hospital system, says, Oh, you're kidding me. You have 7 employees? Are you crazy? And so the thing is, but good employees, you've got to have good employees. And so one of the things is that to get good employees, you've got to treat them respectfully. You've got to pay them well. And they will in turn take good care of you. You know, my clinic is just in the process of implementing an electronic medical record. And this is why I don't have any hair on the back of my head. A couple of weeks ago, I went to my office manager and I said, how are we doing on cash flow? She says, we're doing fine. I said, you know, let's do this. Let's give every employee a $500 bonus and tell them thank you for dealing with all of this inflammation foolishness that we're having to deal with. And by doing that, that made a tremendous impact on the morale in the office. And I give my employees a nice bonus every Christmas, usually right before Thanksgiving, so they'll know that, that we're caring for them. And again, you'll get good employees that way, and they'll be very protective of you. I have an office manager. I have 2 front desk, or actually I have 3 front desk people or insurance people, 2 lab employees, a phlebotomist and a medical technologist, and I have 1 nurse and I have 1 backup nurse right now. But you got to have layers to protect you. You really, really need a really good nurse. I practiced for almost 5 years without a nurse that was dedicated to me. And in an endocrine clinic, this was the scenario that I saw my nurse being torn apart by, come teach Mrs. Jones how to give insulin, and we're ready to do biopsy, And the thing is that I realized this early on, and it was a nurse I was working with that said, hey, I want you to come work for me. And so my salary went down. The $40,000 that I paid her, the next year my salary went down $40,000. But I'll tell you, I wouldn't have it any other way because my life became so much better. And so, by all means, you need somebody who understands what you want and what you're after, and that can demonstrate the type of quality practice that you want to have. So again, the salaries do get quite expensive over time, but again, remember that you have to pay the bills, but you have to have a quality practice. So don't be afraid of these costs here. Now, one of the things that I always say, unfortunately in medicine, you'll hear this a lot. Spend $1 to make 2, or spend $2 to make 5. One of the things is that be thrifty, but don't be cheap. Gosh, I might drive a car that's 25 years old, but believe me, I've got money put aside for an ultrasound machine. I pay for the service contract. I have probably one of the best microscopes in the building. I have a good copier. I have a good fax machine as you're trying to get things out, and I have a good EMR. It's another reason why I'm driving a car that's 25 years old. And so, be thrifty, but don't be cheap. Let's talk a little bit about practice enhancements, and this is something that, I guess is more thyroidology specific. We talk about, for me, the best practice enhancement I ever invested in was having a clinical lab right on site there. Thyroid ultrasound, again, this is a huge part of Bob's practice as well as mine. Nuclear medicine, a smaller part, but a vital part, and the cytology. We're going to talk about each one of these just a little bit.
No, I only have number 2.
We're different. So you got to set yourself apart. What makes you different from other endocrinologists in town? It's coming to meetings like this, and it's learning the most up-to-date of everything. Be visionary, not reactionary. You may not be able to start off with all these things, but have a plan. Now, my feeling and my quote is as follows: thyroidology without lab is like fishing without worms. Lab is critical. And the TSH and free T4 are so critical to what we do. In my lab, we have a from the vein to the paper results in 20 minutes. From the vein to the paper. Working on trying to make that faster. But that way, we can make face-to-face decision-making processes. Are you taking your medicine? Your TSH is 60. Are you sure you're taking? I promise I'm taking my medicine. For some reason, it's not absorbing well. Stand back as lightning strikes, sir.
Must be celiac disease.
I will go ahead and write your prescription now. I'll write a note to the primary physician. But again, doing this all face-to-face. Because for me, an on-site lab gives me the ability to not have 50 charts on my desk at the end of the day. Meaning, lab is drawn, patient seen, lab available, questions are answered, details are addressed, prescription is written, or e-prescription is prescribed. Dear Dr. Jones, I had the privilege of seeing Mrs. Jones in follow-up of her hypothyroidism. At present, her thyroid function is stable. With this, I'd recommend she should have yearly thyroid function tests and a yearly neck exam as part of your yearly annual exam, and then face-to-face. I would be more than happy to see this pleasant lady back in reassessment on an as-needed basis. all face-to-face inside of 20 minutes. And so I think that lab is what makes me an effective clinician. And you?
Well, I see it turnaround.
But the thing is that he has 25 patients that have to be called with TSHs tomorrow.
Well, but we also frequently will have patients come in a day or two before.
So I would say this, for instance, the cost on doing 3,000 TSHs in the office is about $4,500 a year. And this is the reimbursement here. And so, you know, granted, you got to pay employees, you got to pay CLIA lab surveys, you got to pay everything else. But, you know, certainly there is a benefit there. Do we have a cutoff time?
No, I just have a question.
Yes.
So you, what about
Thyroglobulins right now, there are a couple of this as you may know across the country, there have been a few instruments that are desktop instruments that do a good job of thyroglobulin. One was a Beckman, but of course Beckman is having terrible trouble with the antibodies, and so I send all of those out at present. I did have thyroglobulin turnover in 24 hours in-house in the hospital I'm in, but right now all of my thyroglobulins are going to Mayo. So probably about 2 to 3 days on thyroglobulin, but I did have it inside of 24 hours before.
They took my mic away.
Oh. That's bad.
And since we don't do anything in-house, I have a choice of 2 different thyroglobulins. One is to use the Quest assay, and the other is to send them to Carol Spencer at University of Southern California, who runs a very high-quality, high-sensitivity thyroglobulin.
But how long does it take?
For Carol Spencer, it takes up to 2 weeks.
Up to 2
week
weeks.
or two.
Up to 2 weeks.
However, so the way I divide this up is if I have a patient with low-risk thyroid cancer, stage 1 or 2, I typically will use the general lab assay. If I have a patient with stage 3 or 4 thyroid cancer, I typically send it to Carol Spencer because there are situations where the antibodies are interfering and not being picked up in the general assay, but in the high specialty assay they get detected.
By doing your own billing here, though, you can see there is some income based on just doing these tests in the office there. And so by all means, I think it's profitable to have a lab. But again, you got to have everything in place, and you got to make sure your billing is in place, because if you're going to do it, you got to be paid for it. Also with the lab, my lab right now is costing me probably about $250,000 a year to have as we go looking at salaries and everything else. But, you know, certainly it is profitable as well. And so it's great to have these, you know, a lab there, and it's quite helpful. We'll go talk about a few other procedures right now. This is my older statistics here from 08. I need to update that. But again, with the number of procedures, you know, right now, the thyroid ultrasound procedures outnumber nuclear medicine procedures probably 20 to 1. As much as I'm an advocate for in-house nuclear medicine, by all means, get a good ultrasound machine as your first step. Get these other things going before you jump off into that. I do a lot of thyroid ultrasounds, but I do not as many uptakes and therapies, but I would have it no other way than do those. We'll talk a little bit about how to promote without advertising. I know we talked about this, but a good letter informs, educates, and advertises. One of the things that you can do, because, again, we don't have an advertising budget, and you don't want all those disgruntled T3 seekers to be coming to your office with looking at you online and on the on whatever you advertise on. Send a great report. How many of you all are aware of the ECNU certification program through AACE? We got a few hands up. How many of you all are finishing fellows this year? How many are finishing this year? Excellent. How many have turned in everything so you can go to the ACE Endocrine University? So you can. Excellent. I look forward to seeing you there. And so one of the things that we're talking about with the ultrasound now is not just the importance of how to hold a probe, but is how to write a really nice report. For me, I have a nice cartoon at the bottom of every single report, and so this gives you a really good overview, but you send this out to your primary practitioner, whether it be doctor or nurse practitioner, and you got this big right-sided nodule, and they say, oh, so that's where the thyroid is. Well, let me feel the neck. Oh my gosh, I can feel the nodule now, just where they showed him in the picture. You'll have more educated hands feeling necks. You'll have more business than you'll ever know what to do with. You agree?
I agree.
Excellent.
And as we said, it had the logo of the Jackson Thyroid and Endocrine Clinic. I have the Thyroid Center of New Hampshire. People recognize then that is what you do, and they...
How to get in touch with you? how to get in touch with you.
I am always amazed at the number of reports that I will get from doctors.
So one of the other things, too, is that we all become electronic medical record driven. And one of the things when I was in fellowship is that I had one of the attendings come to me and say, your notes are awful. Your letters are worse. Come with me. And he said, sit on that chair right there, and I want you to hear what you need to say, what people want to hear. And the thing is, tell them what they want to hear. Don't go rambling on and on and on. But I received this letter from a friend of mine who's here, and I did address this with him personally, but it was somebody who moved to a different part of the state. And I said to him, I said, gosh, I've got a friend down there. Why don't you go down there and just, he's right in your town. I'm happy to see you back anytime. But I got this electronically generated letter that don't ever do that. You're quality in, quality out, I will say. Garbage in, garbage out. So by all means, try to do what you can there.
We've just started playing with EMR in our office, and I made a decision to not go with a meaningful use EMR at the moment. Now, are people aware of the meaningful use criteria?
Money from the government.
The government came along and said, if you have an electronic medical record that meets these criteria, they have to communicate with other ones, they have to have drug interactions built in, and they approved 6 or 8 different records that if you use them, you could get up to a $65,000 bonus from Medicare in the year.
Right.
I looked at it, and my wife, who's a physician who works for Dartmouth, had made the observation that their productivity dropped between 10 and 20% after they put in the
Very
record.
much so.
And everyone across the board that has put in a new system generates these unreadable reports. Productivity goes down. They spend so much time. One of the fellows from Dartmouth, do we have any Dartmouth fellows here? One of the fellows from Dartmouth working in my office told me that in order to e-prescribe, you needed to click 16 times before you could get that prescription to come out. They were mostly carrying pads in their pockets anyway. They weren't using it. So I instead took the forms that I was filling out by hand, and I hired a pre-med student who's now at Brown, and he designed PDF forms on the computer. Everyone in my office carries around little MacBook Airs. We can punch everything right into that. It goes to the cloud. We all are interconnected. I can pull up my full medical records off of my iPhone at this point. So my productivity went up, not down, by being creative in it. And I know that somewhere down the line, in the next couple of years, I'm probably going to be forced into one, but I'm going to let it all shake out in the meantime. So I'm going to wait till it's absolutely necessary, but my productivity going up rather than down made me more than that $65,000.
But I'd also say this, is that, so I'm going to, I paid about $50,000 for an EMR, plus you got to have a server for your billing and a server for the patient data, and so, be looking at an expenditure probably upwards of $75,000 or $80,000 there. But the thing is that, I tried to make mine as specific to me as possible, meaning one of the things I have done is I added my logo, and so again, gosh, pay the $500 and get somebody to make you a good logo. That I went to my EMR company and I said, I want my logo on my notes, and they said, we can't do that. And they called back a couple of weeks later and said, your logo is on your notes. How did it get there? I'm like, well, duh. I sat there and played with it and figured out how to do it. But the thing is that a lot of my EMR notes, I'm trying to have the quality that a letter back to the physician would have. Meaning, none of this 15 pages of nothing. Meaning, I send 2 good pages, 2 good assessments, and I've really tried to make it to the point. Now, gosh, I don't want ICD-9 codes next to that, but I think we're all going to find ourselves in the middle of all that. But again, try your best to make your output look the quality that you are, and not scribble it on a piece of paper.
What I've done, every new patient.
Yeah, I'm still dictating a letter on every new patient.
On my positives,
yeah.
And I use the form for patients who come back with a benign biopsy.
Yeah. We talk about a few other things. We have until 11:45. Is this right? Okay, let's talk a little bit about other things you can do in the office. Now, one of the things that I was supposed to talk about today that I'll just make mention of is to be an authorized user of radioactive iodine and have that in the outpatient practice. Mainly, this can be done with 80 hours of coursework, board certification by a medical specialty board, supervised treatment of 3 patients with hyperthyroidism, and supervised treatments with 3 of more than 33 millicuries. And so this is something that is very, very possible in your office. And how many of you all had nuclear medicine training in your fellowship program? Anyone? One. Do you go to Brown? Where are you in school? Residency or fellowship. Excellent. Excellent. So, this is certainly a possibility. In my training, I had none. I heard about it. Once the mice experiments went bad, I pursued it. This is something, if you're a first or a second year fellow, hey, do think about this, because this can be done. For me, what I did was I said, I want to learn how to do this. And so I went to nuclear medicine. I went and talked to the attendings there, and I said, I really want to do this. And then I went and met with the radiation safety officer for the place I was working, and they said, well, you know what? If you're going to be moving from here, we could actually put you on our license here, and then if we put you on the license here, you can in turn transfer that license. And so when I moved to Mississippi from Minnesota, I was able to transfer my license. And so there are a lot that can be done in fellowship. If any of you all have any interest in this, please email me or call me or come talk to me. I'm happy to talk more about it. Now, one of the other things that Bob vehemently is opposed to, but I think is very helpful, that I think is one of the greatest things that I have loved more than anything, is in my office I have real-time cytology for specimen adequacy. This has been excellent because, number one, I used to have to see blood in the hub before I would pull out. Now I know all I need is about a microliter of anything to get a nice specimen, and so my quality of slides has improved greatly, knowing what I'm putting on slides. Plus the other things, too, is that at times you will see huge nest of papillary cancer cells, and you'll say, good gosh, before this patient gets up, we need to map the notes. And so to me, this is an excellent help to have and move ahead with that.
So it's got an advantage.
Yeah, I'm quick to say this, is that I could pay my lab tech salary with the DiffQuicks only, with having that. And that's not why I do it. I do it because I really enjoy it, and I've learned so much, and my slides have gotten so much better.
Yeah.
Yeah.
See, my pathologist sends me at least 2 glossy pictures on my cytology reports. So I still get to see what it looks like.
So, but what if you could see it if it's there in real time? Let's talk a little bit about office.
But I already know that from the ultrasound.
That's right.
See, when
He knows everything.
The ultrasound, I know whether the patient has cancer or not. I don't need the biopsy.
You guys are probably going to find yourself, you may be hired by a hospital, and then you may be the first endocrinologist in the area. And so one of the things I wanted to give you a little bit of a tour of is that, so what works for me, and this may not be what works for Bob, but I think the office layout, the proximity of the waiting room to the lab, the proximity of the procedure room to the exam rooms, the proximity of the physician office to the nurse office, and proximity of everything to the lab. And so this is the main corridor in my office. I know that's a really long hall. Place we have my office manager who's supervising the front desk, and so she's there. If a belligerent phone call comes in, she knows that they're talking to somebody, and so having everything in a proximity and is very helpful. You want a pleasant, clean place. One of the things is that where I'm in a hospital building right now, and I'm glad where I am. But one of the things that they said, well, gosh, they wanted me to share the waiting room with the spine clinic, and the spine surgeon says, how often are you in clinic? I'm like, well, clinic is what I do, and so I started thinking about sharing the front office with the spine clinic. The perception of you want happy people in your waiting room. You want a nice, easy access, easy in, easy out, and so perhaps keep the perception of as best you can. I have a procedure room that I do ultrasounds.
Let me just
Yeah, go ahead.
comment on one thing there. They have cancer.
And I oftentimes tell my front office staff, thank you for shopping at Kmart. Don't ever forget that. I don't know if you all grew up seeing that acronym. You go in, and because they would always say that when you check out at Kmart. I always tell people, don't forget that. Make sure that people have a pleasant experience in your office.
And one thing that I've done from day one.
I talk about the procedure room, and one of the things is that as you have a procedure room and then you're trying to negotiate a contract and such, always make sure that you got space to have a nice procedure room. For me, this is kind of my dual action procedure room, meaning I have my uptake probe computer here. I have my dose calibrator for the radioactive iodine. I have a sink in case someone ever throws up radioactive iodine. I haven't had it happen yet. I have my thyroid ultrasound. I have the same stretcher. I have the uptake probe for the thyroid uptakes. I have the cytology information there. I have a place for people to hang their coats. But it's all a pretty small room, as you can see there. It's not a very large room, but it's relatively simplistic. I have my cytology in the back. And so as you go thinking about adding these, and if you're building out a space, for me, I said, I want to have this together. And so I had a chance to have the good things from my old procedure room as I went building a new space and had them for the new procedure room. Also for ultrasound, you got to have a good comfortable chair with the footrest on it. Keep that in mind.
And that is against
One time in my career I'll let them watch.
Really?
Because I always say, I start to shake with that needle in my hand, and if you want to come watch that, but I get a little nervous when people watch me.
See,
I don't do that at all.
I always have
Bad idea.
And I'm used to performing. I'm used to.
But of course, you're dealing with people from the Midwest. We have the people that are crying before they even come in the room.
When
Cry with the alcohol.
When the patient and their family see.
Never. One of the things, I have two nurses. I have one nurse that's very compassionate. I have one nurse that's pretty tough. And the one that I'm around most of the time, the thing is, it's all in how you say it. For me, I always say, you're doing fine. I have this other nurse that says, oh, how are you doing? Don't even ask that. Say, man, you're doing great. It may be bleeding a little bit, but you're doing so well, and we'll be done in just a few minutes.
Yeah, the first thing that I say after I do the first, all the time.
The other thing, too, this is some stupid stuff, but you hear him mention about the monitors. I would sit there and I would try to do the biopsy saying, gosh, am I going to be able to see the screen? Now that we can get, here's a Dell monitor here that, so when I stand up and do the biopsy, I got one there. One of the other things, though, is that when my nurse and I were in the original office we were half a city block between us. And so, if I'm ready to biopsy, I'm like, I hope she's coming soon. I've got gloves on. I'm not going to pick up the phone. I'm not going to run through the office with gloves on. So one of the things that I've done is right there on her desktop, I have put just a VGA monitor so she can see exactly where I am. So when I'm doing my exam, when I sit down and I'm writing or jotting down some notes at the end of everything, she knows I'm done. She knows I'm ready for biopsy, or I can just hit R on my ultrasound keyboard, and that means, Renee, ready for biopsy. And so she comes right in, and it's like she's telepathic or something like that. But the other thing is that, just trying to make use of things that are just simple. And that's off the shelf. That's, $100 for a monitor. So keep it simple.
Yeah, you don't need to buy the needle.
Right. You just need to see the flash of the needle.
The other thing that I learned from Jack Baskin that made such a big difference.
He had a black and white TV, by the way.
No, but when
Yeah,
I
by the
went
way,
to
but
visit his
yeah.
office the very first time when I was starting to do this.
The other thing, too, is that you have to code appropriately, and this is something where some of the AACE courses about endocrine coding would be a big help to you. Because one of the things I use as an example is I helped teach this nuclear medicine course for AACE, and I sat down with some people one day talking about coding, and I realized that, I hadn't been coding. When I do a biopsy, I was doing a diagnostic ultrasound, then I was using needle guidance for a biopsy, and I was doing a needle guidance, and this is all a game of how to code things. For instance, when I do an ultrasound guided biopsy, I use a diagnostic code of 76536. I use an FNA guidance code. I do an FNA code, and I have a cytology code. So it's all about how to code these things appropriately, correctly, safely within the law. And so this is something that I really encourage all of you all to get help on, and to go to some of these courses and learn how to do it.
If you're going to private
promoting the practice, we've talked about this, but one of the things is that you always remember that when you sit down with somebody, you say, okay, who sent you again? And you say, well, who's your primary doctor? Because there'll be like a GI doctor that checked a TSH that was 6 when they were constipated. Always find out the primary. Always find, particularly the young women, find out who the OBGYN is. Who's your OBGYN? And you don't have one, let me refer you to one. And so by all means doing that, you'll always CC all of these other doctors on your letters. That's really simple. That's really cheap, free advertising. By all means, you get an answer to the doctor and an answer back to the patient. Feel free to give good advice. Give free advice. I call nurse practitioners all the time. I had one across my desk last week that was on Armour and Cytomel, that new combination. And I said, okay, the TSH is 0 and they're on this. I said, do this. I'm happy to see them, but this needs to be stopped. And she says, well, she refuses to stop it. And I said, you know what, I can't help here. And so.
And promotion is all over your office.
So, but back to the point about not making yourself a guru. One of the things I do is I see a lot of patients with thyroid cancer, and I know that a lot of the people with nodal disease in particular get beyond the surgical expertise of the area, and I'm quick to tell them, gosh, I want to get you set up to see a surgeon at MD Anderson or a referral center of choice. And so I always offer it first, and people, occasionally people will come in and they're disgruntled because we have some complicated issues that we may not come up with an answer for. And I'm always quick to offer a second opinion and take no offense to that, and I will dictate a nice note to the doctor that's going to pick up next and say, gosh, I look forward to hearing your findings. Pass out a lot of the American Thyroid Association brochures, by all means.
Wait,
yeah?
in terms of that last comment, furious.
And you have to swallow your pride and call some of these surgeons sometime and say, this is what we're going to do.
Yeah, well,
or go look them in the eye and tell them this is what you're going to do. Yeah.
But what I learned from that one, hearing it the other direction.
The other thing is we talk about the EMRs. One of the things that I look back and laugh is that we had an EMR company that had sold their product to a GYN, an electrophysiologist, and a general surgeon, and all their notes were the same. And so I look back at that and I say, gosh, remember to make yourself individual. And so by all means, if you're a thyroid clinic, have thyroid in your name. And, if I could change anything, the wait to get people in to see me is something I wish I could change. Trying to keep up with things. Occasionally I think about stopping Medicare. I know Bob has stopped hypothyroidism altogether, but again, inside
not to the practice.
Not to the practice, just to you. But might we all become thyroid oncologists eventually? Do something you love and you'll never work a day in your life, is what Confucius said. I ask of you all, any questions for either one of us?
You guys were talking about
You need to ask around. Because I'll tell you this, there's a soccer mom that I see at every soccer game I go to who cannot yell anymore because of an inadequate surgeon. And so you need to ask around. You need to go to the doctor's lounge. You need to go talk to the pathologist. You need to talk to the radiologist. Talk to him and find out who's the one who's the best. And you'll learn pretty quickly.
And you can get statistics from the hospital given out this morning.
But it becomes abysmal. And when and the other thing too is that as you start doing follow-ups for your thyroid cancer, and you see a lobe in place in somebody who had a total thyroidectomy, you really learn, who you can trust and who you can't, And but again, you will find yourself in controversies in your career, but learning to deal with them and trying to diffuse them the best you can is of utmost importance. Yeah. Yes. I have not. I mean, I get things all the time. I mean, what I'll get is I would get something sent to me by fax. There's a physician that always faxes me on Thursday afternoon, and it's a TSH of 0.1 in an 85-year-old lady. What do I need to do next? And I say, make sure you have a free T4, get me an uptake and scan, and let me know where we are. And so I don't give any complicated advice other than, go ahead and get them started on thyroid hormone, and I'm planning to see them inside of a month. But again, they appreciate that you have looked at what's coming, and that you are very aware of your wait time, and that you're acknowledging that you appreciate them sending the patient. Yeah. Any other questions? Thank you all for your attention. We'll be up front.